In this live recorded session from our Talking HealthTech Winter Summit, we tackle one of the most critical issues in healthcare today, the shortage of clinical coders. This episode was supported by THT Plus partners Infomedics, and the discussion highlights how digitising medical records can help bridge the challenges we face of shortages in clinical coders in Australian hospitals. You'll hear insights from the speakers and our audience throughout the session as we explore practical solutions and real-world examples. Keep an eye out for our next virtual gathering like this. Our Spring Summit is happening in November 2024, so check out our website for more information. Collaboration starts with a conversation, Team Health Tech. Let's make it happen. Digitising medical records is a critical priority, but what happens when you don't have the workforce to make it happen? This session will explore strategies for making digitised records accessible to remote experts, reducing the burden of paper storage on hospitals, and ensuring that clinical coding needs are met efficiently. This is session number 3 of the Winter Summit 2024, brought to you by Infomedics, titled Break Glass, When the Clinical Coding Workforce Can't Be Found. Please welcome Ravi Carothers, Head of Health Fund Relations and Revenue at Healthe Care Australia. Nicole Payne, Head of Transformation of Revenue Cycle Management at Healthscope. And Chris Mitchell, Chief Information and Digital Officer at Hunter New England Local Health District. In preparation for this session, we asked our community, what's the biggest challenge in digitising medical records? Nearly half of respondents, 46%, said cost of implementation. 21% of people said data accuracy is the cause. 18% said accessibility of records, and only 15% of people said workforce shortages. Let's go to the panel to see what they have to say. Tell me a time that you're going to be able to get 30 minutes with 3 hospital executive leaders from public and private across Australia. I'll tell you the time. It's here at the Winter Summit right now. I'm very lucky to be joined by Nicole, Chris, and Ravi, who I will let you give some bit more context in just a moment. But do drop a message in the chat, ask those questions, and inundate us with content to discuss, because we've got loads to get through, but want you to shape that conversation. Firstly, I might go to let's go to Chris, because you're not a stranger to the summit session and format, and it's always great to have you here. Thanks for joining. Representing Hunter New England Health. This conversation that we're having is about the journey that each, I guess, hospital group and setting has had on digitising medical records, and we'll go into that and what that means in a second. But set the scene for your region and what that means and what that journey has been so far.
Yes, got a couple of tech challenges this morning. Hope you can hear me okay.
Well.
Oh, good, thank you. So good morning, everyone. Yes, we've been on the digitising of the record journey for quite some time, since 2009, well before I joined Hunter New England Health, to be honest. And that background was actually from some challenges with storage, being mouldy paper, actually. So not only did the challenges stem from digitising the records themselves, we actually had to remediate them first to remove mould and all kinds of other nasty stuff that was giving us a few WHS headaches. So our journey started as long ago as that, and we have been scanning paper ever since. So we see it as a real mechanism for the secondary paper storage, and we've rolled it out very across a great number of facilities in Hunter New England Health, and are in the process of starting to develop some processes to actually backscan what you might call a tertiary storage type records as well. So it has been a long and epic journey, and I completely understand the cost part of the survey that was up on the screen just before. It's definitely a challenge from that perspective. However, there are some interesting benefits, which I assume we'll get to later. Thank you, Peter.
Yeah, no, thank you. I love that, if you're a newly minted hospital executive or a CTO or CIO coming into a role thinking you're going to talk about all these innovative robots and large language models, and your first challenge is how to remove mold from paper records, that certainly is a bit of a reality check. So, Nicole, over to you to set the scene from your side.
Yeah, great. Hi, everybody. Really great to be here today. So I joined Healthscope late last year as the head of transformation, and to have a look at the way that we can address some of our big issues that we have. And a lot of our issues stems from not having a workforce in coding. So being a private hospital group that is owned by a private equity company, you could imagine the focus on the importance of revenue cycle management. So one of our big barriers, 39 hospitals right across Australia, and really large hospitals down to small hospitals, but trying to find the workforce to be able to code records. And because our records are still paper based, and yes, I know that some may be surprised that we're still paper based. The earlier session, speakers were talking about their EMRs, and privates could only dream of having an EMR. So um, to find staff that can go on site and actually code records is real challenging. And so the way that we've approached it is having a look at how do we digitize medical records. We have caught up prior to the session and we started talking about, well, what does that mean? And one of the most important things is actually defining what we mean by digitizing medical records. So we're talking about scanning or digitize or EMRs, but for us here at Healthscope, our first step is getting a scanned medical record in. And so along with a bit of digital medical records, but it's sort of, that's what's driving us today. Our drivers is really focused around getting the records coded to support our revenue cycle management. So sort of that's where we're at. We haven't deployed anything yet. We're still going through that process. But 2025 is going to be the year that we will be transforming our service and that we will be having digital or scanned medical records available for our coding staff.
Exciting times indeed, and you raise a great point about it's one thing for us to all sit here and say let's digitize all the records, because why on earth would you have any paper, and that of course makes a lot of sense, but the understanding the why and then, because that's going to drive a lot of the priorities and the demonstrating the return as you suggest, because that's important everywhere, but in the private hospital space, that's also critical, which is a good opportunity to throw to Ravi to give some context from the Healthe Care side. Over to you, mate.
Thank you, Peter, and good morning, everyone. So Healthe Care, similar to Healthscope, private hospital group owned by private equity, smaller scale than Healthscope, and we're relatively early in our journey of digitizing records. We've got a number of our larger sites do scan records to allow coding to be done remotely, and I think similar to what Nicole said, we're going forward, and it was reflected in your poll as well. The challenges really are around the cost of implementation in a sector that's challenged with a whole variety of costs, and particularly with our owners having that return on investment, when in reality there's a number of things in terms of digitizing records around the workforce where it's actually quite intangible. It's around allowing flexibility for people, allowing the right skills mix, and how you can access those people in different locations in Australia. And that's obviously quite hard to convey to people who look at dollars and cents and worry about the bottom right-hand number. So I think that's a challenge that a lot of us have, and I would hasten to add, Chris, it's not like the public sector has an unlimited budget either. So it's a challenge for all of us.
Absolutely, and that's probably a good opportunity for us to provide that clarification too, because the focus of this session of digitizing medical records is around that need for clinical coders. And if you're not familiar with this requirement or the space of having clinical coders do what they do within a hospital setting. You might, and if you're in the technology space, you might hear coders and think that it's the app developers, writing the code, the HTML or whatever, or the different code behind the scenes for the tool. But that's not what we're talking about. It's the those that kind of provide that translation between what's in the system or written on the bit of paper from the clinical side, and then translating into a format that can be ingested, and usually for billing purposes. But Chris, talk to me a little bit more about the requirements from the coding space. And I think everyone's touched on this too, is that it's a little bit of a rare breed, a specific type of person that does this clinical coding that is sometimes not in the fanciest office of the hospital setting, let's put it that way, but is pretty critical. Talk to me about the clinical coders in your side.
Yeah, look, absolutely a critical part of the workforce, no question about it. And often, as you mentioned, Peter, very much sort of up behind the scenes, but absolutely critical when it comes to so many different perspectives, right? So, excuse me, the revenue and billing is absolutely one aspect of it, but it flows through to Medicare, which then flows through to diagnostic resource groups, which then flows through into population health and trends and all that kind of stuff. So, as a workforce, they are some of the unsung heroes that we really have all throughout the health system. And I think, as both Nicole and Ravi alluded to, the workforce is getting more and more challenging to find, and we are having to be more flexible. And this sort of, I think, starts to lend itself to that conversation around the digitisation of the paper record. So when a clinician from one end of the hospital says, "Hey, I need paper record 1, 2, 3 from 3 years ago," what would have happened historically is that one of our record management people would go and get the record and run to the other end of the facility and give it to the clinician, and then go and get it back a couple of hours later. So lots of sneaker net type work, I suppose. Whereas now they get that same request, they run it through a batch scanner, and it can be available on the clinician at the other end of the facility screen sort of within seconds. So there's and that's just a couple of examples of things that the records management and coding workforce do for us. And then probably the final one I'd just like to touch on is one of the unintended benefits that we've seen as we've rolled out the digitisation of our paper records. And this is scanning, not OCRing. So just to be really clear, scanning, lots of paper notes with very messy handwriting. So what we found was when we're doing clinical governance type reviews, rather than having to send a clinical governance person to drive for however many hours to a facility. I think one of the complex things here is that the 130,000 odd square kilometres that this health service covers, that's a lot of driving to go and review some paper records. The time savings that we've seen from a clinical governance perspective to actually get their hands on those records and do some of those clinical look-back type reviews has been an unintended benefit, and has actually started to free up some of our clinical governance staff as well as making life a bit easier for our coders. So this stuff actually touches way more than just one area of the health service, I suppose, Pete, is probably my that.
That's a great point to make. And what I did want to come back, I was looking through the chat there because there's a great question about like some of the technologies that we need to implement this kind of thing. But the Nicole, from your side, speaking about the clinical coders, and I think it's not a situation that's unique to any one health system. It's not we don't have an infinite pool of people that have this capability. It's not even something you can kind of cross-train people in. So as healthcare continues to increase in demand, we've got to find different ways. We're not going to be able to match the demand in terms of people, right? So there's got to be a new way to do it.
Yeah, exactly. And I sit on part of the Health Information Management Association board, and one of our big strategies is having a look at the coding workforce. So what we're finding is coding has become complex, so more complex. So over the years, we've added complexity into coding. Secondly, the demand and the activity that goes through has increased. So we've got more work to do in a more complex environment. And now, because it's tied to our funding, we get heavily audited internally and externally. So, you know, we could expect up to 30% of our work will be audited. So we've now got to also factor in that a lot of work is getting checked. And so there's lots of feedback that needs to go back to coders. So there has to be a lot of coding education and coding training. So we really need to think about different ways of how to address this issue. So one of our drivers is that if we can digitize or scan records, it allows us to then have access sort of centrally, where we can then look at that flexible work arrangement with our staff. And we can also start to direct work to more complex cases, could go to more experienced coders. So we can start to sort of change the way we allocate our work within Healthscope. We can have a look at more of our junior staff that are coming through, could do the easier things, and they're a bit quicker on the easier sort of day. So we want to have a look at that, not only, you know, how we work remotely, but how do we allocate that work? And the other piece that we're also doing is that we want to explore other technologies. So how do we start to OCR document? So we now know that there's been a lot of development in that technology, and it's getting better and better. So we want to have a look at some, you know, we're using some large language models, we're looking at some bots. So we are sort of approaching it from a different way, but without having digital records, we're really limited in being able to use large language models. So the way that we see, by putting in a digital medical record, it also allows us to connect into our VMO rooms. So what we want to do is that we don't want our doctors to have to double their work. So they go back to their rooms, and often they're dictating, and it goes into their software within their rooms. We want to tap in and get access to that, rather than asking them to do it twice, because they don't want to do it twice. So without having a digital medical record, we can't actually ingest from other systems. So one of our key things is having that repository where we can ingest from many different clinical systems, many different VMOs rooms, and also like to the connection up to the My Health record. So that is another really key driver for us to sort of address it from a number of different ways. And also, we know with the workforce, it's often females, and they're often at home caring for children, and they want that flexibility to be able to work on weekends and out of hours. But without a digital or scanned medical record, we can't offer that. So they have to come on site during business hours. So, you know, just also we've got to be, you know, thinking about that workforce, and that they want that flexibility. So sort of that, they're our real key drivers for us in our transformation program.
Makes a lot of sense, and I love that, you know, as Chris alluded to earlier, once you've done you can have an implementation to meet these requirements. There's kind of the core benefits and subsequent benefits we'll probably get out of it, but then there's all the unintended benefits that come out of it too. Chris, I forgot to ask you, did you say sneakernet before?
I did say sneakernet.
Such a good one. I'm just totally stealing sneakernet. The reliance on.
There's an amazing amount of sneakernet that goes on in all of our hospitals, even today.
Love it. So that using the sneakers, the shoes on people's feet as the form of where, yeah, and there's a lot of that going on within the hospital system. Hey, I wanted to touch on this one too, Ravi, and maybe kind of to build on, you know, Nicole's already touched on some of the types of technologies that are used, or looking at, you know, once we can do this, then here's some technology that we can utilize. I'd love to hear from your side a little bit more about how you think about what are the different technologies that might, you know, I guess enable this, that are being looked at or thought about, because Christian's asked the same questions in the chat too. What are the primary methodologies and technologies employed to digitize medical records?
Right. Yeah, thanks. I mean, I probably may not be the best person to answer this, given we're very early on in our journey. So to Christian's question, at Healthe Care at the moment, we keep it very simple. It literally is a scanner at a site with someone feeding the record in. And then we have what's very excitingly called a vendor neutral archive, which is basically a repository where people can log on remotely and review that scanned record. And so where we're at now is actually looking at the next steps, and, you know, Nicole's touched on a few of them around, you know, is there a place in this for robotics, in terms of assisting in coding, more fancy systems that can assist our coders beyond just having a scanned record in front of them. And I think one of the other things, Peter, just to go back to one of the earlier comments that popped up around, I suppose the tension between digitization as a method for revenue cycle management, speed to cash, versus clinical quality. I mean, from our perspective, it's definitely both. I mean, a big aspect of our scanning program is scanning records where there may have been a hospital-acquired complication, and actually allowing for a timely review of that, and also for that to be reviewed by all of the relevant people across the business who are not co-located. So we are central health information teams in Melbourne, our head of clinical quality is in Sydney, and we have clinical quality staff spread around our network, Newcastle, mid-north coast. So it's definitely both clinical quality and revenue cycle. I think probably for people like myself, potentially Nicole, it's more drilled in around the revenue cycle piece, because that's the language that gets used more often when you're talking to the CFO and things like that within your business. But I can assure people that there's definitely a focus on clinical quality in this, and our ability to up our game in that space is definitely aided by scanning these records and having them properly reviewed, and having people who know who to call. So having clinical coders who know when to bring in the quality and risk team, know when to refer back to the site for more information, that's enabled by the record being scanned, digitized, and sent to a senior person who may not be anywhere near that particular hospital.
Yeah. I'm glad you pointed out that one, because that certainly got the chat moving in terms of that question around, why is the I guess return on investment the primary driver for some of this when it's not the clinical quality side. But I think you've unpacked that pretty nicely, Nicole. Given that and I'm keen to hear Chris's perspective too. But Nicole too, I can see others within the chat too have pointed out the importance for the responsibility of the board to ensure that the thing is a going concern is paramount. And that was Kate in the chat there, but also I saw Jody somewhere too point out the need for having a viable business to do both. Lots of other comments in there too. What's your kind of take on this tension? Is it a tension? Is there something else that we need to kind of factor in for digitising?
Yeah, I think it's a really great topic to talk about, because it really comes back to that relationships that the public hospitals have with their doctors and the relationship that private hospitals have with their doctors. So what we find in public hospitals is that the public hospitals employ those doctors, and they're funded generally through their state government for EMR implementations, and they've achieved a lot through EMR implementations. And it's a lot of the doctors that are now trained. New doctors are coming out and getting trained in EMRs. In private, we don't employ our doctors, so they are contractors into a private hospital. So they actually run their own business, and they may go and attend mini hospitals, and they have their own software that they use. So one of the challenges that we've got is that when we want to digitize records, it's about onboarding the VMOs into our ecosystem and getting them access. And that is one of the biggest barriers that we've had, is how do we get our doctors to onboard into our systems and to use our systems when they work across many different hospitals and they use their own software. So some of the messaging that we get is that they would rather have rather sort of interconnect with us, and sort of that we talk within their systems and our systems. So more interoperability between the two systems. So based on that, the way that we have been able to progress this within a private hospital is that the main driver is about our coding and our coding workforce. So at this stage, our our clinicians won't be accessing the system. It is purely digitising records in stage 1 for our coding and auditing workforce. And what we're hoping that, part of our journey, that the second part would be then to having a look at onboarding the VMOs. But the minute that we start to look at clinicians and onboarding, it becomes too complex and too hard. So what we've had to do is take it step by step so that we can actually get the foundation in to be able to then get an end result. So that's the way that we're sort of dealing with it. And, in an ideal world, we would love an EMR and we'd onboard every clinician into our system. But the reality is that there's so many barriers to achieving that today that we've made the first step of digitising for clinical coding and for revenue cycle management as our first start. And that's where we think we can have some success, and then we'll continue our journey into the future.
Yep. Love it. Thank you. And Kerry, I'm glad you brought up the quintuple aim as well. I think that there's a famous girl on a taco and burrito ad here in Australia said "Por qué no las dos," which is why can't we have both? I don't think that will end up in my one-liner quotes from the summit today. Maybe it will. That was a niche joke that some may get, others will think was weird. Now, the what was not a weird suggestion was one that came through from Jadamani, who brought up this point, Chris, about how is there this opportunity for having these done not within the four walls. And I'm pretty sure both Nicole and Ravi suggested this is, one of the main drivers as to why they're looking at digitizing records, because if we don't have the coders physically there to do it, being able to have someone else elsewhere do it. How are you thinking about utilizing a more remote workforce within Hunter, New England to do something?
Yeah, look, it's a definitely an interesting concept, potential privacy and ethical minefields and all that kind of stuff, sending case mix things or offshore and maybe even within different states in the country, actually. But we'll put those things aside. There's definitely opportunity there. But I think one of the other opportunities, and somebody was going to have to say this, and I'm well aware that we are teaching on the edge of the trough of disillusionment when it comes to AI. However, I would see over the coming years, one of the real genuine use cases of AI in the healthcare setting is around coding and supporting our coding workforce. So as we know, the number of coders is decreasing. The flexibility desires are increasing. This is where I see an opportunity for something like AI. So rather than a clinical coder actually manually reading a scribbled piece of paper and then transcribing that entire CD10 or whichever clinical coding may be required to provide the case mix, that the coding workforce become checkers rather than actually transcribers. And I think, from a people and workforce satisfaction perspective, from an efficiency perspective, and really sort of a name that more sort of different way of doing things, I think there may actually be substantial opportunities with AI in this space. And don't get me wrong, I'm not saying that we're going to automate coding out of existence. That will never happen. But to augment and make quality of life better for the workforce that we got, I think that's probably a genuine reality.
Yeah, absolutely. Look, I think that's critical. Like I can see here, the chat's also asking questions, which we won't get time to kind of unpack. I'd love to just about, what kind of studies have been done to demonstrate this return on investment. The conversation is ongoing about quality versus value, and some people got my old El Paso ad joke, so that's lovely. I can see here more from Kerry about the what's happening in New Zealand too. Whilst we won't get time to unpack all of that, I will use this as a quick opportunity to mention as well, Bernie from Informatics is highly responsible for bringing us all together here in this conversation. And thank you for Informatics for making this discussion possible, and certainly well-versed in that process of digitizing paper records and a lot more too in the hospital space. So definitely check out their listing on the Talking HealthTech website if you've not already, to learn more after this. But perhaps a minute for each of you to be able to kind of wrap up and provide a summary in terms of next steps from here and the priorities and how you're balancing all of this before we wrap. Nicole?
Yeah, probably when I think of it from a professional perspective, today we had HIMA had their first launch of the AI task force for clinical coding. So I can see there's lots going on in the chat with that. So from a professional group, we've started that piece of work now, looking at coming up with some industry guidelines. For Healthscope, we'll continue to progress into the digital medical record. That's our plan for 2025. Whilst we continue to, look after our current coding workforce and grow it and be able to provide that flexibility. So that's sort of what's going to keep us busy.
Amazing. What about you, Ravi?
So I think for us, it's, maturing on our journey to something more than just a scanned record and bringing the tools to assist our coders to make their roles more fulfilling and take some of the more menial stuff out. And I think that, will help with the recruitment and retention of the workforce, and also aid, clinical quality in those parameters. And I think the only final thing, just to answer one of the questions in the chat, in terms of offshoring and outsourcing, every time we've looked at it, the Privacy Act and just the risk averse nature with people's health data just puts up probably too many barriers. I think a lot of people have talked about duties of directors and going concerns and what have you, having, dealt with the Privacy Act in many roles. It's not one I'd want to get on the wrong side of.
Yeah, no, that's right. There's a lot to, as soon as you're sending offshore, there's a few red flags there. Chris, bring us home in terms of, at the different end of the journey, but one that's ever ongoing, no doubt.
Absolutely. Continuing to the focus for us next is what we might call our tertiary storage. So this is the really, really old pieces of paper that quite possibly nobody will ever look at, but we are bound by law to retain. So for us, I really think it's getting into that tertiary storage and looking at some of those onshore, but perhaps outsourced type processes to augment the already stretched workforce and bring a bit more of that quite old paper back into a digital system of some description. I think that's sort of what our next 12 or 18 months in this space looks like, with a dollop of the AI stuff as well, hopefully.
That's right, with some innovation that might be built on from there. So, Chris, Nicole, Ravi, I really appreciate making this time. Love this conversation. Look forward to doing it again soon. Thank you so much.
Thank you, Peter.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.